Hi, welcome to You Didn't Get the Memo. I'm your host, Gloria Bailey Ray. I'm excited that you guys decided to join me because, as always, we have an exciting show. So, greetings to all of you, wherever you are. Thank you guys so much for tuning in. A little bit about You Didn't Get the Memo show. As a reminder, we are here to provide you, the viewer, with relevant, factual, mainstream information to help you be informed and to make informed decisions. A quick reminder to all of you also that You Didn't Get the Memo show is now airing live not only on Facebook and YouTube, but on LinkedIn. Additionally, the You Didn't Get the Memo show airs on Comcast Channel 28 and 33 in Berkeley and Comcast Channel 10 in Oakland. If you have any questions or comment for my guests, be sure and place them in the comment section and we'll do our very best to respond to them. Now, my guest today is Dr. Kim Rhodes, and in my opinion, one of the many unsung heroes who are providing services and doing things in the community, especially in the BIPOC community. And so I want you to join me in welcoming my guest, Dr. Kim Rhodes, to the You Didn't Get the Memo show. Dr. Rhodes, thank you so much for taking the time out of your, I don't know how you do it, crazy busy schedule and joining us. So thank you so much for being here today.
Thank you for having me.
Yeah, absolutely. Well, let's just get started. One of the things I always like to do is kind of ask my guests to just tell our viewers a little bit about your backstory. What's your backstory, where you grew up, and importantly, why did you choose medicine as a career choice? So talk to us a little bit about that.
Sure. So I grew up in San Diego. My father was in the Navy. And even though they were getting shipped here and there, once we started school, my mom said, we're not going to move anymore. So, we'll wait for you when you come back from your various deployments. And so I grew up in Southern California. When I was in 8th grade, my favorite teacher told me, you need to go to Berkeley. And so from the time I was 14 until I went to Berkeley, I was committed to going to Berkeley. I majored in linguistics. I didn't major in any kind of basic science, even though I was, good at and enjoyed science. But I majored in linguistics because I enjoyed languages, and I think had sort of an innate feeling about the importance of communication and being able to really connect with people regardless of what the barriers are. I decided to go to medical school probably when I was a junior, I think, in college, because I couldn't figure out what a linguist does for a job. And my mom had been an administrator at the UCSD medical school really since, I was 3 years old. So I had kind of a sense of, the experience of people going to medical school and the stresses that come with that. And also an understanding that, some people would graduate or get to the point of graduation and then turn around and say, well, my parents wanted me to do this. I didn't really want to do it. And so I decided to take a year off between college and medical school to really decide, is this really what I want to do? I moved to Washington, D.C. I did HIV research, really basic research in the lab, studying actually variants of HIV before we had the term variants. And it was during that time when I realized that, yes, I like basic science. I'm really good at it, but I'm not really touching the people. I'm not connecting with people here. So that was what really spurred my decision to go on to medical school. But when I got there, what I really intended to do was, as I say, get inside, understand all the secrets, because I knew that that our people really disenfranchised and alienated from the clinical settings. And I wanted to know what the secrets were so that I could then come back to the community with all the training and insider information, and then expose all that information to the community. And so that I'm fortunate, because even though that dream was over 30 years ago, I am getting to do exactly that in terms of being able to bring the knowledge that I have and the background that I have in the different types of research that I've done in clinical care to share with people how to get what you need out of a system that really has secret languages that you need to speak in order to access what you really need.
Yeah, I think that is critical. Of course, my initial meeting with you was at one of your pop-ups, and I was just so enthused and excited to meet someone. You could just tell you love what you do. I mean, you're so engaged, and when you find people that have found their passion and they are making a difference, and that's why I wanted to celebrate what you're doing. Here you are out here in the Black, Indigenous, people of color community, and helping us all to navigate the system, and I think that was critical. So as the founder of Umoja, tell the viewers about your organization. Why does it exist? I think people already kind of got a little snippet of that, but really and truly, why does it exist, and what are the goals of your organization? And then we'll transition into talking about some of the types of patients that you treat.
Sure. So so let's see, where do I start? So I worked as a colorectal surgeon for many years. I was on the faculty at Stanford from about 2008 until about 2016. And during that time, I was tapped to lead the community engagement work out of Stanford. Some people may be familiar with the Breast Cancer in African Americans conference that was under my office for many years. But when I left, I was recruited to UCSF to run community engagement in the Cancer Center at UCSF. And I have been doing that since 2018 when the pandemic hit. And one of the pillars of our mission is year-round, non-transactional community engagement. And what that means is we're here whether we have a study for you to participate in or we want something from you, which is very typical of academic institutions. We always want something from the people. We don't always give anything back. And so what I set out to do was change that paradigm and say we are always going to be giving something back, or we're going to come and we're offering something and we're not asking for anything. And so what that means is it's an invitation to ask us for help and guidance and access to the resources that we have, whether it's for cancer or anything else. And then, of course, in 2020, COVID hit. And what our community partners started asking for was information about COVID. And true to that mission pillar, we said, okay, we're going to give you back COVID information because we're in a scary time right now. Nobody knows what's going on. People don't understand this virus. We don't understand this virus, even in academic institutions. So we know that communities would feel even more afraid and alienated. And so we started providing a newsletter with COVID updates. That newsletter covered any information. It was like a clearinghouse. So any information UCSF was giving out from the Latino Center of Excellence, from the Asian Health Institute, we were sending out opportunities for people to get the information in different languages. And one day I realized that there was nothing specific for African American people. And that was really disturbing to me because I could feel the power of what we were doing to keep people connected, but I realized that that was going to communities that were not intentionally focused in the African American community. UCSF around that time started providing testing, and you may remember at the beginning of the pandemic, there was no testing, was not available, wasn't easily accessible, and so when the folks who really started the United in Health initiatives did their work in the mission, what they found was that the Latino people in the mission in San Francisco were 100% of those with infections when they did mass testing. And then the non-Latino people who were sheltering in place and working from home had no infections. And that's when it sort of became very obvious in March and April of 2020 that this was going to be a socially defined distribution of COVID disease. And what you couldn't get in any of these communities of color was any testing. So the chancellor at UCSF, Dr. Sam Hawgood, tapped me to lead the efforts in Bayview, Hunters Point, and Sunnydale. And because I already had community partners there, we were working on cancer and environmental exposures, it was an easy transition into COVID. We were then subsequently asked to come over to Alameda County. And what we recognized in Alameda County was that even though they were reporting high rates of infection in some parts of the county, when you looked at the map on testing and whether or not people were testing a lot in those areas where the rates of infection were high, the testing rates were low. And then conversely, where the testing rates were high were like Piedmont and Berkeley and North Oakland, where the infection rates were extremely low. And so we could see there was a mismatch there, and decided to bring the community together to say, we need to provide this service community members providing the service to community, because we know who really needs it and maybe who is not able to get access.
Yeah, absolutely. And for those of you, and thank you, I see we got Arkansas in the house viewing here. So thank you guys for tuning in. For those of you who are wondering, of course, UCSF, University of California, San Francisco, I mean, it is a huge teaching institution. And we personally have been touched by a lot of the work with one of our grandchildren that had to be there. And just what you guys do, the work is phenomenal, and which was why another reason I wanted to celebrate what it is that you're doing, so people know this isn't just somebody just kind of fly by night. When I say that Dr. Rose is entrenched, I'm telling you this sister is entrenched. Y'all not hearing me. It's in her veins, okay? So to hear you talk about those things, and you're absolutely right. I think that that was one of the things early on that as a whole, the country as a whole, they're doing this testing, but wait a minute, we're not in the right place and we're not with the right people. And the people who were affected the most were people of color. Right. No question about it. And so that was the other thing, just talking with you, that just had me just so caught up with, and I just always feel that it's a blessing. You know, God gives you people that you need to talk to. And I was just blessed to be able to talk to you, but to see the engagement of your staff too, the volunteers, and how these people are in it. This is why I do what I do. And this is why I have people like you on the show to talk about. So you talked about getting into the community, and really, we really need to have the testing going on. And with the testing, what we were able to find out when we really, you know, you talk about, you ratchet it down to the real folks, the people of color that were not getting tested. This is where we found that so many, you know, people of color were just, I mean, people lost their lives for lack of knowledge, lack of testing, lack of access. And I, you know, so that I'm on that trajectory with you to make sure that we educate people and inform people. And that leads me to the question that I had, is the type of people that you treat at Umoja Health. So you've talked about, you know, first of all, I mean, you just specialized in cancer research, HIV. Now here we are dealing with COVID. But let's just talk about kind of like a generalized overview, and then we're going to take a quick break, and I'm going to come back and we're going to ratchet it down to, you know, in particular, you know, different populations and groups. So when we talk about overall, if I just say, give me a 10,000, you know, foot view, what types of patients are you treating? Or I should say that you don't treat at your job. How about
that? So because we were focused on the places where testing wasn't available, these places were parts of our county that were heavily populated with African American people. We also serve, of course, we serve anybody who shows up, and that's kind of part of our of how we do what we do. Zero barriers. We want to reduce every possible barrier, including if we've got to bring it to your house, we're going to bring it to your house. So we serve whoever shows up, but we always looked at the top line number to say what % of our resources are reaching the African American community, because often we don't pay attention. We say we're going to do a good deed, we're going to do it in communities of color, but we don't actually track who we're serving. So we really focus on that top line. So when we were testing early in the pandemic, our services reached over 50% of our services reached African American people. The majority of people who tested with us were actually first-time testers, and that was important because it meant they hadn't been engaged in the conversation around COVID. We also were starting to ask people who would be interested, for example, in vaccination. And what we were seeing was that the African American community wanted to come to us. I think they started to trust us pretty quickly because they were responding at the higher rates of being willing to be contacted for research and a higher rate of interest in vaccination than when you compared to the national average. And that's because I think of how we were delivering the services, who was out in the front of the top pop-up site, what color our tents were, the, you know, sort of the signaling that we do with our colors here, and the symbol of Umoja being unity in Swahili. So we really were able to reach African-American communities, people with no insurance, people living in low income settings, because of how we targeted where we were going to show up and deliver service.
Yeah, I think that it not only is so critical of the things that you talked about, but you said a key word is trust. And as you know, throughout the medical community, when it relates, especially Black folks, it has come to, there's so much mistrust, distrust. And one of the things that from your organization, I just see this, you know, the truth, the transparency, the accountability, you guys are standing on that. And that is really, really important. And I just think that anybody in the medical community watching this, that they need to understand that that's the first key. People got to trust you before you expect them to get engaged and get involved. And that's the key thing. So when we come back, we're going to take a quick break. But when we come back, Dr. Rhodes, let's just talk about, you touched on the resources, but let's talk about those services within your pop-up clinics and what that's like and what people can expect when they attend one of those. So we'll be right back. You guys, thank you so much for tuning in. Don't go away. We will be right back.
Whether it's advice on managing your anxiety or tools to help you stay grounded, Coping-19 provides a range of resources and self-care tips to help you cope with this pandemic. We can help. Find the resources that work best for you at coping-19.org.
Before we celebrate the freedom most Americans have, we must fight for the freedom all Americans deserve. Because all lives can't matter until Black lives matter.
Right, and because you just tuning in, you are tuning in to Get the Memo show with guest Dr. Kim Rhodes. About honoring the work that she is doing in her community. So, Dr. Rhodes, before we went to break, one of the things that I asked you to do is let's talk about the services that are being provided at your site.
So our resources have evolved over time. When we started out, we started with testing, but we knew that people weren't going to just show up for testing. So we had what was called a social services pavilion, where we were providing access to resources to address food insecurity, resources around connecting into primary care, resources for housing and back rent, and those kinds of things that were also secondary effects of COVID. Some of those, and then we were also offering actually HIV testing and counseling with CalPEP, one of our partners, and we offered flu shots. At this point, because we were able to reach a population that very clearly had not been reached before, the County of Alameda gave us our own vaccine allocation and allowed us to continue this pop-up style. So because we had testing to begin with, we always offer testing and vaccination together, which is unique, I think, to what we're doing. But we also offer information about back rent, because there are, some of the rescue funds and CARES Act money was available for that in Alameda County. If you test positive at one of our sites, we offer what are called wraparound services. So we do case management. That's a phone call on a daily basis. That's groceries and PPE delivery to your home. And then we try to make sure that people are linked to care. So as we disconnect from them, we want to make sure that they actually have a primary care provider, have a pathway into that. Right now, because it's Breast Cancer Awareness Month and because COVID is becoming what we hope. We want it to be a side dish instead of the main course. We're starting to offer information about breast cancer screening and trying to encourage people to get back to their primary care and preventive health behaviors, because those have dropped off during the pandemic, and they're going to disproportionately affect and have bad outcomes for people of color. And so we'll rotate that through all the different cancer awareness months. The one place that we didn't get to that I think is still critically important, and although we don't offer it at the Umoja sites in Alameda County, our Umoja affiliate in San Mateo County does offer some mental health services. So right on site, they'll do a mental health minute with folks and just sit together with them and do some sort of guided kind of calming relaxation exercises. That's something we would love to have on our sites. But what we provide is whatever the partners who are in our meetings with us, whatever they're bringing to the table. Because the one thing I didn't say is that Umoja Health is not really an organization. We don't have a not-for-profit status. What we say is we are a method, and what we are is a method to raise the community voice and elevate its importance and its impact on how our public health departments, who all sit in our Umoja tables in 3 counties, San Francisco, San Mateo, and Alameda County, to raise the community voice and concerns and to demand answers and accountability. And so what we can bring to each of our sites depends on which partners are available to be at our sites with us, or who can bring something to the table. It's like Stone Soup. It is community serving community.
Yeah, absolutely. The things I love the fact that you talk about this wraparound service, number one, which is critical, and it seems to be a piece that's missing in a lot of organizations. You know, you come in and you look at this one thing and we forget about it, but it's the other thing. And mental health. Thank you for saying that. We did a show a couple of weeks ago about suicide prevention and mental health illness, and it's real, and it's something that needs to be addressed, and still there's so much that really and truly needs to be done in dealing with that. And I know across the country, but right here right now, this is what we're dealing with. But I want to ask you something, because I want to get to getting vaccinated. But let's talk about the challenges with getting people of color to just even get tested, because the nice thing that you guys do, not only do you test, you vaccinate. You know, it's kind of like the one and done piece, right? And to get the status, your COVID status right away. And I can speak to that because I come in and what I say, I just felt like I needed to get a test today. And I did it, had my test results. It wasn't even 24 hours. I mean, I got my test results almost immediately. So let's talk about, one, the challenges of getting people of color to get tested, because people say, where's this going? Who gonna get this? Is somebody gonna know about it? That kind of thing. So that comes down to a privacy information piece. And if we could talk about that, and then from there to go into, because I really want people to hear you talk about, we didn't do the nasal swab. And that was different. And I really want people to hear your take on why you didn't do that. So I asked a number of things in between, but let's just start with the challenges, first of all, of getting people tested, please.
Well, so when we first started in San Francisco in the Southeast sector, trying to mobilize in the African-American community, the thing we were hearing was, you're going to give me COVID by putting that swab in my nose. And I don't trust government testing, and you're trying to infect me, and often that would invoke for people the Tuskegee study, call that study lightly, without realizing that the men were not given syphilis. That didn't happen until they moved it to Guatemala. So that's a whole other story. But people were afraid that we were infecting them. And so that was the swab was a really big deal. And then the discomfort of the swab, because at the beginning of the pandemic, we were doing deep nasal swabs in what's called the nasopharynx. So that's a way to reach through the nose with the swab to touch the throat, the back of the throat, because it's all connected back there. So when we started, we backed off of the deep swab. We came to what's called the mid-turbinate, so it's a medium level swab. But then by the time we got to Alameda County, the Yale saliva-based protocol had been approved, and we knew that our community, who A, did not want a swab in their nose, B, were suspicious that there was something on the swab, and C, were concerned that, we were in some way contaminating things. We switched to the Yale saliva protocol because people can do it on their own. We're not touching them directly to get the test. You just put a little bit of saliva in the tube, and we send the tube to our lab where it's processed. I'm sitting in one of our labs right now. This part of why we are able to return things so quickly is because our lab is right here in Oakland. But we knew that was going to be a game changer specifically for who we had heard from in our community that we were serving, was the African American people really didn't want to have something inserted. And so the saliva-based test has been a godsend and a blessing, because it means that we are much more portable. We can take the saliva-based tests out just in a backpack, walking around our local lake where people like to gather, and offer people testing in that way. So those were some of the big barriers. It's really about, trust of who's providing the test. I guess the other thing you did kind of bring up is this issue of privacy and who's going to get the information. Absolutely. We do, in our consent, we let people know what to expect in terms of phone calls, right? The state needs to know that you've had a test. If it's positive, the Department of Public Health in your county needs to know that you had a test, because they need to do the contact tracing piece. But I think what helps us get over some of that is that we're not testing and leaving you. We're right. Testing, and then if you're positive and you're going to get all these phone calls, we're calling you first, and then we're warning you. These are the phone calls that are coming. These are the reasons that the phone calls are coming. And then we encourage people to please participate, because we want to make sure that we can stop the spread of the virus.
Right. Dr. Rhodes, I want to ask you, let me digress for just a moment. You talked about the saliva test, and I've heard differing views. Everybody got a point of view. Mm-hmm. And I have been told, oh no, that the saliva test isn't as accurate as the nasal swab. Now, me personally, that nasal swab, I wasn't feeling it at all. It's so uncomfortable. But yeah. What do you say to people, because it depends on what side of the coin or the track that you're on. You got people, mm-hmm. Oh no, it's definitely, you got to have the nasal swab. And like I said, I have been privy to having both, and I prefer the saliva. So what do you say to people who say, how accurate is this? Does it really work? Is this for real?
Right. So it's not, the accuracy of the test has more to do with what you do with the sample after you collect it. Mm-hmm. Than it does with where it came from. In the beginning of the pandemic, we thought a nasal swab was better than an oral swab. And then we figured out, the oral swab is actually equally sensitive. And that's the basis for the saliva test. Mm-hmm. And in fact, what I would challenge people to understand is that sometimes when we do saliva-based testing on people who have come back to get a confirmatory negative test after they've gone through COVID, the saliva-based testing still picks up a positive test, which is problematic, because if your employer is requiring it, which is actually not legal, you may still have to stay home because the test is a little bit too sensitive. So I discourage people from using our testing to confirm a negative test, because if you have COVID, then the saliva-based test actually is a little more sensitive. We are running what is called PCR, polymerase chain reaction. That is the gold standard for testing for COVID. So where people might be getting confused is about the sample collection. What they should be asking is, what is the test you're doing looking for? That is what's going to tell you how accurate the test is. So you want a PCR test or a LAMP test, which is like PCR and is provided by the company Color. But PCR is still gold standard above LAMP.
Right. Okay. Look, I got it. All right. So we talked about COVID. That's a great lead into talking about COVID, because now we're dealing not only with, just COVID-19, but now there's a Delta variant. And I have gotten a number of videos of people who are saying that, you know what? Just what you said, that myth. Oh, they put something in it. They're tracking me. They're doing all these things. And I want us right now to dispel that belief and talk about, you know, first of all, tell our viewers what exactly is now the Delta variant, because, we're getting conflicting stories from even
Right.
at the top level, down to, here in the community. So let's talk about what the Delta variant is and, what's available for people who test positive, whether it's for COVID or for Delta, the Delta variant.
So first of all, I really want to acknowledge that the messaging from our public health infrastructure, which is the CDC, on down to your local public health departments, the messaging has been terrible. It's been horribly jumbled. And I think this is the linguist in me who always wants to make sure that we're connecting, is to point out that, like, the communication is not a successful communication. If you say it, but somebody doesn't hear and absorb it the way you intended, then that's a failed communication. And we've had a lot of that. So COVID-19 is called the novel coronavirus because our bodies as human beings across the world, every human being, no human being has ever seen this virus before. So that is the SARS-CoV-2 coronavirus. COVID is the disease caused by coronavirus. Just want to be clear about that. So when you're talking about variants, what we're talking about is a change in the DNA of that particular virus. So let me see if I can explain this. DNA is the genetic material that is like the roadmap for all the different parts of the virus that need to be made, okay? The most important part of that virus, we think, is that spike protein, and that's why we're training your body with the vaccine to recognize a spike protein and kill it. But what happens with DNA is when it duplicates itself. So when cells divide and, for example, let's say the cells of your skin, which shed continuously, or the cells in your mouth that turn over, when you burn your mouth, it takes about 24 hours and then suddenly the burn is healed. What's happening is the cells are turning over. In that process, they're dividing and making new cells that should look just like the one that was the original cell that divided. So DNA is a double-stranded entity. So you can imagine a zipper, and when your zipper, when the teeth are fitting exactly together right, the zipper works. When you get a change in one of those teeth, the zipper doesn't work, right? It's just destroyed. You can't get the zipper up. DNA has two sides. Those two sides have to match like a zipper. What happens when the cells divide and the DNA replicates itself, like makes copies of itself, it makes mistakes. And so instead of getting this, you may get this. That's the variant. So it's not a different virus. It's still coronavirus. It's still SARS-CoV-2, and it still causes COVID-19. It just has a mistake in its DNA. Lots of your body makes mistakes like that too. Okay, that's actually cancer, and that's a whole other conversation, but that's what happens with cancer. So your body can make these mistakes. SARS-CoV-2 or coronavirus can make these mistakes. Sometimes the mistakes don't matter. They don't make any difference. It still behaves the same way. What happened with Delta is that mistake made the virus better able to transmit itself from one person to the next. It gave it this superpower that allows it to force your body to make more viral particles than our original SARS-CoV-2, but it's still a SARS-CoV-2. It just has some special features. That's what a variant is.
Okay. And wow, what an excellent, I love the zipper analogy. That's a great analogy. And that leads me into the question, when someone tests positive for COVID, and I love it, like you said, SARS-CoV-2, And I think that that's the type of terminology that we need to start really embracing and speaking. And thank you for just being transparent, because the communication has been so flawed from the CDC down till it's at a point where people are like, that's why. It's like there's no consistent messaging whatsoever.
Right.
And the worst thing in the world that you could do is have people in the country to just say, I don't believe any of this. It's already people thinking it was a hoax given, our previous administration, and now with this. But someone tests positive for SARS-CoV-2, or even just, the COVID virus. What options do they have? Because people have thought, it's just a total death sentence, but that's not exactly true.
Right.
If they test positive. So how do you handle that and manage that with those patients who have a positive test?
So I think people thought it was a death sentence because coronavirus killed so many people in the last year, became the number one cause of death, surpassing heart disease and HIV, and cancer as number one causes of death. Those were 1 and 2. And now coronavirus is at the top. What we still don't understand about coronavirus infection that we all call COVID. So COVID is the disease, right? What we don't understand and cannot yet predict is who is going to get super sick and who's not going to get sick at all.
Right.
And that's where the studies are going now. But in the meantime, we have very few treatments for it. That's why people have this death sentence-y kind of feeling around it, because we're not very successful yet at really intervening. The things that we do have that work to keep people out of the hospital or to reduce the severity of disease is the monoclonal antibodies, otherwise known as, under the company name, Regeneron. I think people probably first started really hearing and paying attention to that when the former president was given that, at the time, experimental therapy. It seems to work well. So if you are in what we consider a high-risk category for having a severe episode of COVID, like if you have asthma, or you have severe and uncontrolled diabetes, or you have really bad high blood pressure or heart disease, or any other of these kinds of comorbid conditions, we consider people who have those as high risk for getting really sick if they get infected with COVID. So with the coronavirus, so the Regeneron, or the monoclonal antibodies, are something that you have to ask for. It won't be offered to you. You have to ask, where is it being given in my county? Who's providing it? Can someone please get me a referral? And that would be your primary care doctor, more than likely. Beyond that, what we have is, you're in the hospital. We can give you oxygen to help your lungs function better. We can turn you, some people may have seen this, have you turn on your stomach to do breathing. That just changes the dynamics in the lungs to get more oxygen into the blood. Then we have monoclonal antibodies can be given in the hospital. Steroids can be given in the hospital. And then there's remdesivir, which is another type of precision medicine that can be helpful. But none of them are absolutely guaranteed to cure the disease. Once you get beyond those medications, then you're talking about being on a ventilator and having your breathing supported, having your blood pressure supported with other medications, depending on how sick you get. So we don't really have a lot in our armamentarium against COVID and against the coronavirus. That's what people really need to understand, and why we're pushing so hard around prevention.
Right. I think that it's also important to know, and that's interesting, and thank you for bringing that point up, is that if they were eligible to receive the monoclonal antibody, that you got to ask for it.
Yeah.
Now, going back to the communities that you serve, getting the word out and making sure that people are aware. We had someone on who actually has an infusion clinic, and we were talking about it, and I witnessed firsthand with a family member who had just come back from a wedding over in Mexico, their COVID test was negative. And they get home 3 days later and they came down with COVID, tested positive. And I was able to have this information to share with them. But I find it interesting that you've got to either know somebody who knows about it in order for you to ask about it, because it's not something that they are offering. And when I look at the BIPOC community, right, those are people more so than anyone else that probably need to have this information, and
that's right,
to get it pushed out to them again, which is why we do the show. So hopefully people will pick up on this and say, wait a minute, I tested positive. But there is a caveat, if I recall. If you've tested positive, you need to get that infusion within 10 days. Otherwise, it's not going to work. So is that your understanding in regards to receiving the
Yeah, so we ask people who are test positive to isolate for 10 days, right? After that 10 days, we say you're no longer infectious and you can kind of be out and about. So it would make sense that you need to get it within 10 days. The reality is you need to get it in the first 3 days.
Right.
And the reason for that is, and this is something that I think also has not been messaged very well, is that the first 3 days of the infection is the virus making you sick. The last 7 days to 10 days of that process is your body trying to fight it off and therefore making you sick. So your body is giving you a fever to make an inhospitable environment for the virus. Your body is releasing immune cells, which release inflammatory factors that cause your body to be inflamed. So what the reason you need to get the monoclonal antibodies in the first 3 days is because those antibodies are directed against the virus. And those first 3 days is when the virus is really the thing that is doing the damage. So I would recommend people get on Google, and I will put in the search bar, where can I get monoclonal antibodies in my county?
Absolutely.
Monoclonal antibodies near me. So then you'll be prepared. And when we call people, when we find out they're positive and we provide the wraparound services, the first thing we offer is a referral to the monoclonal antibody infusion center that we've identified here in our county.
Like I said, this is why I'm celebrating you doing those things that make such a huge difference. You guys, you're tuned in to You Didn't Get the Memo. I want to thank you guys for hanging in here. We're going to take another quick break, but you are listening to the dynamic Dr. Kim Rhodes, and we are, just celebrating all the things that she does. And as you can tell, I had a comment that says you're extremely smart, and they're really impressed. And I said, yes, she is. So we're going to come right back. And Dr. Rhodes, when we come back, I just would like for us, one, to talk about an op-ed that was published in July, August 2021. Black San Franciscans really need to get vaccinated against COVID-19. Let's kind of talk about that a little bit. But you guys don't go anywhere. You're watching You Didn't Get the Memo show with my awesome guest, Dr. Kim Rhodes, and I'm your host, Gloria Bailey Ray. We'll be right back.
Let's get back to talking smack with the side of mac and cheese.
Before we can safely come together, we need the facts on COVID-19 vaccines.
To get the facts, visit getvaccineanswers.org so you can make an informed decision when vaccines are available to you.
Home fire drills give your family a plan of action. Show everyone 2 ways out of the house, pick a safe meeting spot, and get there in under 2 minutes. Then practice so everyone knows exactly what to do. Go to ready.gov/fire drill and learn how to prepare your family.
Thank you for watching the You Didn't Get the Memo show with your inspirational host, Gloria Bailey Ray. It's your contributions that make this happen. To become a sponsor, send an email to youdidn'tgetthememo@gmail. That's the letter U, didn't get the memo. If you're not in a space to be a sponsor, but you like what you hear, we simply ask that you support what you like by making a contribution to the show. There are 3 ways to make an online donation. Visit paypal.me/Gloria Bailey Ray or Cash App or Venmo, Gloria Bailey Ray. Give what you can. Your support is appreciated.
All right. Thank you guys for hanging in there. I am talking with Dr. Kim Rhodes, who is a physician, and she is here in the community doing work, doing stuff. And look, I'm giving you your crown, your flowers, your roses today because of the work that you have done and you continue to do and give so much of yourself. Before we went to break, a question that I asked you was about an op-ed that was published August of 2021, and it talked about Black San Franciscans really need to get vaccinated against COVID-19. And I know that I personally see in the news, they talk about how San Franciscans are really on an upward trajectory. But talk about that article because there was something that prompted that. And of course, again, that's only a few months ago, July, August. So tell us a little bit about that.
Yeah, I was the lead author was Dr. Ayanna Bennett, who is a physician and a public health administrator in San Francisco. And I think one of the things that probably tweaks a lot of us who are African American and, you know, working in these spaces is just the way we celebrate kind of overall numbers, and we don't dig deeply into, you know, what's missing. What are we missing by giving the top number and celebrating that San Francisco is, you know, over 80% vaccinated? Because when you break it down, what you see is that the vaccination rate in the African American community at that time, I believe, was somewhere in the 50s, maybe touching the 60s%, and that's not really high enough to feel comfortable that the community is protected. And so she brought this piece to me, and we worked on it together with a few of our other colleagues who are African American and on the faculty at UCSF, just trying to really to say we care, and we care very intentionally about select communities. Doesn't mean we don't care about everybody, but it means we're trying to give the love that our communities are often not getting from public health institutions. And I think what's really important, and this is something I say to people who say, well, the government, you know, just wants us dead. And I don't differ with people when they say that. But what I do remind them is that even though the vaccine was not created for us, because really hardly anything is intentionally created for our community, the vaccine prevents severe COVID, hospitalization, and death. That's what it prevents. And those are the things that were disproportionately impacting African American people across the country. When you look at the 700,000 deaths that we've had across the country, about 25% of them are in the African American community. We only represent 13% of the population, so we are nearly doubly represented in deaths in COVID. And so I remind people, yeah, they didn't make this vaccine for us, but guess what? It's actually for us. And you know how I know? Because they tried to keep it away from us when it first rolled out. We were not at the top of the list to get the vaccine when they first started distributing it. And in fact, we saw people coming into neighborhoods where they would never be caught dead in their Teslas, with their computers, you know, trying to get the vaccine. And so that just goes to show you that the vaccine is for us. And in order to preserve our lives, we needed to really engage with that. And that was the impetus for that article, that op-ed.
Yeah, and you bring up such an excellent point. I always say that in order for you to have a solution, you got to be willing to be a part of it. Mm-hmm. And a lot of what you're saying, I mean, we would see on the news that there were, you know, whites who were in Black communities and were lined up to get the vaccine. And so, you know, you got to stop and ponder that. This other thing is I know that a lot of clinical trials, they are not done. When you look at the number of people of color, especially African Americans that are in clinical trials, it pales in comparison to, you know, white counterparts or colleagues. And so it's very different. And we've got to get that mindset and change that in order for us to, have drugs that are developed and better for us. But I thank you so much for saying, yeah, it may not have been initially meant for us to get it, but you know what? We have it and you need to take advantage of it.
Mhm.
And, talking about want to live, and I hear, the COVID vaccine is going to kill us. Well, if you don't take it, well, let me just tell you what your alternatives are probably going
Right,
to be.
right.
And I think that we have to kind of look at that, from that perspective for sure. So my question to you, because we've covered a lot of things, there are still people who have that issue around getting vaccinated, and especially when because you're in the trenches, so you're talking to people who know beyond a shadow of a doubt they are, when I say they are basically no income, how they're living, they're in a desert community, there are no grocery stores, no
Mhm.
fresh vegetables,
Mhm.
just no
Mhm.
access to things. So have you conquered, or at least attempted to scratch the surface on combating or overcoming the concerns that people of color have? Because that old saying, you can lead a horse to water, but you can't make them drink, kind of thing. And
Mhm.
I just see you out there. I mean, I'm watching you my husband and I sat in our vehicle and we're just watching you and watching your staff, and you're so inviting. And I just want people to know that you may not have all the answers, but you darn sure close.
um, well, have we? I don't think we've won the battle, but I think
Mhm.
what we have done is changed public health, our academic institutions' perspective on how to do the work. And I think that's critically important because that's something that can stick. Right. That's something we can take into the next thing that we're going to have to work against, because we are going to have to work against a number of old disparities. So we haven't won the battle, but we have convinced people that we need to stay longer. So in the beginning, when vaccinations were going great and the infection rate was down to 1%, everybody was like, okay, are you guys going to stop? And I was like, no, you all are done. We're not done. Right.
Right.
Because when you're looking at that top line number, it looks like we're done, but we're not. And so what we can't do is now abandon the community. So I'm just going to tell you the truth. Even when COVID's over, Umoja is still going to be doing something in the community, because there's really no way that I can go back to my regular day job after this. So and then there will be the opportunity for people to still get the vaccine, even if it took them 8, 10, 12 months to decide, okay, now I'm ready. We want to be there when they come to that decision. So
Right.
we are just patiently waiting without judgment to provide whatever we can to uplift the health of the community. And I think that's the impact that we've had, is that people see that this needs to be year-round, non-transactional community engagement.
Yeah, I agree with you. And that again is literally what people see. So if I were to ask you, Dr. Rose, what's on your wish list? What would if I could wave a magic wand, which I hadn't got to that point yet, but if I could, what are some of the things that you would like to see or like to have in your arsenal as you continue to work in the community?
Big question. I think fundamentally, all of my efforts are really about seeing my people and myself to be free, to be fully who we are, and to not have Umoja be special because it's intentional around African American people. That shouldn't be special. That should be normal and expected. So part of what we're doing through Umoja is we're trying to groom the next generation of people who are working inside healthcare institutions, and public health. So we have a number of intern programs. We've got a number of our volunteers who are headed off to medical school and have all written their essays about working in Umoja. So I guess if I had a magic wand, we would fast forward to a time where what we're doing is a normal part of medical education, is a normal part of engaging young students in high school and middle school to learn about health equity, structural racism, and start to prepare people to dismantle it, because it is going to be the next generation of folks who are going to continue to try to tear it down and rebuild it. And I would love for that to be fueled by Umoja. So what we're trying to do now as we talk to funders is really talk about funding a long-term investment in not only the direct health and healthcare services in minoritized communities, but also the long-term investment in the academic, educational, economic advancement of the people who are currently disenfranchised.
Yeah, absolutely. Dr. Rose, this is my last question for you. What do you want people watching the show today? What do you want them to take away?
I want people to really feel and understand and grab hold of and use their agency. You have a voice. You need to be activated and an activated citizen, participating in, who our leaders are and voting for things and redistricting, a lot of which is going on here in California, so that we can start to tilt the tables to our own advantage. And so what that means in terms of COVID and coronavirus and misinformation, disinformation is try to find your credible sources, and whatever it is that you learn, spread it to your community networks, because there's bound to be someone who's going to be touched by this information that will change how they feel about things or cause them to take action. And what I have seen in this process of building Umoja is the power of the people. It's not all doctors. It's a lot of community folks coming out to save community. And the power in that is inspiring. It's what keeps me going. But it's also, I feel like it's yet unharnessed. And so I think I want people to wake up and recognize that they actually do have the power to make change, especially if they do that in community and in partnership with others.
Yeah. Thank you, Dr. Rose. I appreciate it. Listen, I don't want you to go anywhere. You guys hang on. So Dr. Rose, stay right there. I'll be right back. To those of you who are watching the show today, I want to thank you guys so much for tuning in. As you can see, I personally am very passionate about the education and the information piece that we need to get out, especially to our BIPOC community. So I want to thank my guest, Dr. Kim Rhodes, for being on the show today. A gentle reminder to all of you this is an ask, is to support our efforts by inquiring about our sponsorship packages or opportunities, or if you just like to be a supporter. If you're not in this space to become a sponsor, you can still support by making a donation of any amount. There is a blessing in the giving. Hey, I want you guys to be sure and follow me on all my social media platforms, and that's all of them. And mark your calendars for every Tuesday at 5 p.m. for another great show. Today was a special show, and I am honored to have been able to bring it to you. If you're in need of some midweek inspiration, be sure and tune into my podcast, Real Talk with Lady G, every Thursday at 6 p.m. on Spreaker. That's Spreaker, Spreaker.com. And hey, get inspired. I want to give a quick shout out to all my viewers, to my donors, the sponsors, and to thank you all. As I always say, if you didn't take anything away from today's show, then it's you who didn't get the memo. Be sure and join me next week as we go to Youngstown, Ohio, and chat with Sophia Buggs, an urban and medicine farmer who is the owner of Lady Buggs Farm. Until this time next week, have a great week. Give thanks for all of your blessings. Stay safe, and always remember to pay it forward. Remember this, that the quality of your life is determined by the decisions that you make. I'm Gloria Bailey Ray, your host. Peace and blessings.